We can. Now, do you have a genetic predisposition, or you're just in this for the education?
All the above. So just
Okay.
a quick overview. BRCA2 positive, found out this past spring with a routine mammogram that turned out not so routine, and wound up having DCIS in the right breast, wound up doing the genetic testing, had the bilateral mastectomy, had DCIS in both breasts and invasive in the right. So that's just my quick overview. So happy to be here.
Okay. Okay. And still have ovaries and everything in place?
Negative. I had the BSO in early July. So.
Oh, great. Okay.
Yeah.
So you're in good shape then.
Yes.
Good. Okay.
Trista, would you mind doing a short introduction?
Hi there, can you guys hear me?
Yes.
Yes.
Sorry, my video is not working, but I just found you guys on Instagram. I'm an ovarian cancer survivor, but I do have a genetic mutation, the ATM gene. So I was diagnosed with ovarian cancer at 31. So just kind of, and I'm currently in remission and doing well. I'm just looking for more information on how I can help prevent breast cancer occurrence.
Okay, perfect. So that's good to know, because I didn't include specific data on ATM, but I'm quite familiar with it. So we can talk a little bit about that when we come to it.
Great.
Thank you for joining. What I'm going to do is I'm going to mute everybody for now. Everybody's done an introduction. I'm going to mute everybody and we're going to get started. So good evening, welcome. Thank you for joining. I'm Tracy Milgram-Posner, the founder of BRCA Strong, where we empower, educate, advocate, and empower survivors, and thrivers to eliminate the feeling of isolation and help you feel whole again. Due to COVID-19 and not being able to get together in our normal groups and functions and panels and transformational photo shoots, we're sending out care packages to women who are just diagnosed, who are having surgery, or have a family or friend in need. You can please reach out to myself or Kate as a board member, and we'd be happy to send a package out. Tonight, we have Dr. Carcas on, a medical breast oncologist, who I'm happy to work with always and have around in educating our community, as that's really what we want to do right now, is continue to empower and educate as many women out there as we can and touch as many women's lives, because screenings are being put off, different things are happening due to COVID-19. So thank you so much for coming on, Dr. Carcas, tonight, and dedicating your time to making a difference in our community.
Perfect, thank you. So I'm going to share my screen and start this PowerPoint. Let me know if you can see. Are you able to see that?
We got it.
Okay, so let me start up here. All right, so as Tracy said, I am a breast medical oncologist. I also see gynecologic malignancies, and I have a very deep interest in hereditary cancers. So I would say that probably close to 15 to 20% of my entire practice has some gene mutation that predisposes them to a malignancy, specifically breast and GYN cancers. But I do quite a bit of genetic testing for the community, since there is a shortage of genetic counselors. So I am part of the Miami Cancer Institute, but really what I wanted to review with you is some breast cancer statistics in the US. We'll look at the screening guidelines, the impact of COVID, because I just think that it's incredible what the data actually shows. And then we'll talk about cancer care and screening specific to high risk. And then at the very end, like I said, I put in a picture for the new resources that are coming to Broward. I know not everybody is local, so that won't really be of interest to everybody, but for me, it's my new office home. So I'm super excited that I've been waiting for 3 years for. Okay, so breast cancer globally, it is the most commonly diagnosed malignancy among women. And unfortunately, globally, it's also the most common cause of death and cancer-related death. Fortunately, in the United States, it is not the most common cause of cancer-related death. It is the second most common cause. Lung cancer, believe it or not, is a more common cause of death among women. However, in young women, so ages 40 to 49, it is the most common cause of cancer-related death. And I think that that's a really important statistic to know, particularly with regard to hereditary mutations, because we know that those patients in general have a higher risk at a younger age with more aggressive disease. And this is really why I think all of the confusion around screening in the last couple of years is so frustrating, because there are some societies that recommend screening beginning later, 45. And here we're talking about patients 40 to 49. So really, where does that data come from? I always like to look at this because I think in many ways it tells us a lot just about cancer in general. You can see this is the estimated new cancer cases among men and women. And obviously we're focusing on women and talking mostly about breast, which I know quite a bit about, but 30% of the new cancer cases in women this year will be breast cancer. So the highest likely malignant diagnosis. And you can see, which I think is interesting, is lung cancer is actually only 12%, yet more patients die from that. And we know that that is a more aggressive disease, but still nonetheless important to note. So this is just looking at the trends, and this is from 1975 through 2016. And really the incidence of breast cancer has really remained stable. Lung cancer is starting to decline, but what's interesting is that liver, I think I might have put it in the next slide, liver and uterine cancer is actually on the rise. And part of that is because we are not really healthy. As a society, we eat way too much fat. There's a high rate of obesity. So there is higher risk of having fatty liver disease, which is an increased risk for developing liver cancer. And being overweight increases your total body estrogen, which actually increases your uterine lining and thickness and increases your risk for developing uterine cancer. And that is important because we see a lot of patients who do have uterine cancer. It can be hereditary, associated with something called Lynch syndrome, also colon cancer. But that's something that we still need to note and be cognizant of. The estimated deaths, this is what I had already explained. Lung cancer is most common. 22% of the women who die from die from cancer in this country die from lung cancer. Only 15% of the deaths are made up from breast cancer. And this I always just think is really exciting to see, because as an oncologist, you want to see success. And I think that by seeing the fact that the trends in cancer deaths by males and females is declining continuously is just such an encouraging sign that, number one, we're educating better, number two, we're screening better, and number three, we have better treatment options for patients that can ultimately lead towards cure. So this is actually what I was explaining to you among the patients. Let me minimize the pictures there. Okay, so you can see over in the little boxes on the right that the uterine cancer is actually on the rise since 1990. So much of that has to do with the fact that we have a more sedentary lifestyle, people exercise less. I think that our food is injected with a lot of hormone, which absolutely increases our exposure, growth hormone. And unfortunately, it's hard to get away from a lot of that, but nonetheless, it does increase that risk. And looking at the liver and intrahepatic bile duct, that's also on the rise, very much because of that increased fatty liver, which is a true risk factor for that disease. So just looking for 2020, this is the estimated new cases. So 276,000 in women and a little over 2,600 for men for breast cancer, with deaths being about 42,000 and 520 for men. Interestingly enough, men tend to be diagnosed at a later stage of disease because, number one, they are less likely to think that it's breast cancer. And number two, they're often misdiagnosed. And I think that that's a really important thing to think of, particularly in the group of patients who might have a hereditary predisposition or a gene mutation. because we know that those patients do have a higher risk of having a male in the family with breast cancer. So if you have been tested and test positive for a gene, it's really important that all of your relatives that could also be positive undergo testing, because it can truly save their life and prevent that misdiagnosis, because the index of suspicion is so much higher. But this is really important. And Diana, I think that this is really what you want to see. So you would be considered localized. And if you see, this is the 5-year survival and for all stages. So that's stages 1 through 4, 90% of patients are alive at 5 years. For localized disease, so early disease, 99% of patients are alive at 5 years. And regional disease, which is breast and lymph node, 86%. And I actually think that we're doing better than that. And we recently had a new data come out of how to further reduce that risk by offering an additional anti-estrogen blocker for the high-risk patients. So I think that we will continue to see that number decline. And then distant disease, it says 27%. I will caution you that this data is through 2015. And despite every year me checking to see whether or not it has yet to be updated, it really hasn't. And part of the reason it hasn't is we're doing so much better. In order to get a survival statistic, you have to have a death. You have to have an end point. And we're doing so much better with our stage 4 disease that people are actually not dying at the rate that they were before. So I think that we're going to see over the next several years, this percentage for distance survival continue to increase because our treatments are significantly better. And this is kind of just a reiteration of what I've said. So since 1989, breast cancer death rates have decreased rapidly, 40% decline through 2015. And that equates to more than 325,000 avoided breast cancer related deaths. And that is really in all age groups except those high-risk women under 50. So I think that that's, again, just a little asterisk that I would put there and say, you know, we need to question what these guidelines were that are not paying attention to these younger women. And we really believe that the decreased mortality and doing better in this realm has everything to do with improvements in treatment, but probably even more so education and early detection. So how do we continue to improve these statistics? You have to know the risk factors. You have to know what the risk factors for developing breast cancer are. And this is just a quick schematic of what they are. So increased breast density. We know that the recommendation for women who have dense breast, which is usually young women, is to get not just a mammogram, but a mammogram with an ultrasound. You have to remember what the mammogram is actually doing. It's an x-ray. Just like an x-ray of your leg, where your bone is going to show up white because it's very dense. Where your muscle is going to show up a little bit hazy white gray because it's less dense than the bone, but more dense than the fat. Then the fat is going to show up almost completely black because it is the least dense. When breasts are fatty, they show up black and cancer shows up white. So it can be detected very easily on mammogram. When you have dense breast, you're basically looking for white, which cancer shows up white, in a field of white. It's like a needle in a haystack. So the ability to use that ultrasound can help overcome some of those changes. We also know that prolonged use of oral contraception does increase the risk of breast cancer. And in the risk population that we're talking about tonight with the increased risk of hereditary cancers, so gene mutation cancers, if you have an increased risk of ovarian as well, actually the oral contraceptives will be protective with ovarian. So it's a catch-22, and that's when you really have to take into account your family history in order to better direct your risk and your ordering of your procedures, okay, and how you would schedule your procedures. Hormone replacement therapy after menopause. So really what we're getting at is that any prolonged hormone exposure, because we were designed to start our periods and go through menopause, not to continue with hormones forever. The longer your breasts are exposed to exogenous hormones, the higher the risk for developing breast cancer. We know this from a huge study in the 90s looking at hormone replacement therapy in tens of thousands of women. And those women had decreased heart disease, but they had significantly higher risks of breast cancer. And that's when hormone replacement therapy really fell out of favor. I will say that in patients who undergo prophylactic mastectomies and prophylactic TAH-BSO, removing your uterus if you need to, but definitely your ovaries and your tubes, those patients can consider hormone replacement therapy. It's definitely a discussion with your doctor and your team. Some patients are uncomfortable with considering doing so, but I do have plenty of patients who are followed closely with myself and with their gynecologic oncologist who are young and went through a really early menopause and find much more success in maintaining their quality of life. Alcohol intake. This is something that a lot of people don't like to hear, especially during the time of COVID. When I was on my way home tonight, I was listening to the radio and it said that alcohol use of more than 4 drinks, and this is just among women, among 4 drinks within 2 to 3 hours has increased by 41% since the shutdown. So I think that's either because all these moms are home with their kids or they're home with their husbands all the time. Somebody needs a break, right? But what we know is that any alcohol use more than 3 drinks per week increases the risk of developing breast cancer by an additional 20%. So that means if your risk is 20%, then 20% of 20%, it increases it more. It's not 20% plus 20 would be 40%. Okay, it's really, what would that be? Increasing it to 24%. Okay, but still, if you keep doing that, it increases exponentially with more than 3 drinks per week. Early menstruation and late menopause, again, it's just a matter of exposure to hormone. Obesity also, and this is really key because unfortunately our country has become an obese country. And listen, I've gained 12 pounds over quarantine and I've been working the whole time, so I have no excuse. I don't know what has happened. But with weight gain, you increase your belly fat, and belly fat increases total body estrogen stores, and the majority of breast cancers are hormone receptor positive. Although BRCA1 mutation holders can have a more frequent likelihood of having a triple negative tumor, BRCA2 and many of the other hereditary cancers like a CHEK2, ATM, a lot of those actually more frequently have hormone receptor positive breast cancers. So any obesity or prolonged hormone exposure could actually increase those risks further than just the gene mutation themselves. Again, same thing with late childbearing. Late childbearing is considered after age 30, so I'm at risk, but it has everything to do with the hormones again. And then gene mutation, that's family history, important to know the family history and to determine whether or not you have the risk factors that would lead to genetic testing. So this is why family history is so important. Women who have a family history in just one first-degree relative, so that means either parent, sibling, or a child, have about a 2-time increased risk of developing breast cancer over the course of their lifetime. So if the average woman has about a 12.5, 13% chance, and you have a mom who had breast cancer, you actually now have a 26% chance. If a woman has more than 2 first-degree relatives with breast cancer, she has a 3 to 4 times higher risk, so significant. And most women, however, who do have breast cancer have no family history. And that's obviously separate from hereditary cancers. But when should genetic testing be considered? So I believe in the American Society of Breast Surgeons and the American Society of Clinical Oncology. We all believe that everybody who has cancer should be tested. But insurance companies really rule the roost on this, and they tell us what we can and can't do. But family history of breast cancer, prostate cancer, ovarian cancer, that should absolutely be brought to the attention, particularly ovarian cancer, because if you have one relative who had ovarian cancer, you can likely get genetic testing covered by your insurance. Strong family history of colon cancer or endometrial cancer, again, that increases that risk for the Lynch syndrome, which is really important. And I have multiple patients who have Lynch syndrome and have had breast cancer. So there's potentially a crossover link in their risk there as well. Family members diagnosed with cancer at a young age, particularly triple negative breast cancer at the age prior to 60. And then really every metastatic breast cancer patient should undergo testing, because that testing might open up another option for therapy. We now have targeted therapies that can treat patients who have a gene mutation. They're called PARP inhibitors, and they're for patients who do have a pathogenic, so an at-risk BRCA mutation or BRCA-like mutation, or patients who have recurrent ovarian cancer. So just a quick review of BRCA1, BRCA2. You guys probably know this more than I do, even because you've lived this, but we know that these are really important tumor suppressor genes. So in the normal state, the BRCA1 and the BRCA2 genes code for a protein that is basically a spell checker. And it goes through and it breaks in the double-stranded DNA. So the double-stranded DNA is that double helix. It's the spiral staircase that codes for our entire body and our entire life. And daily we get little breaks in it and we have little misspellings. But when we have a functional BRCA2, it goes through and it says, oh, you're wrong, let me fix you. And it fixes it. And it prevents DNA damage. But when you have a faulty BRCA gene, you don't have that backup system. And you develop accumulated DNA damage, which then results in increased risk for cancer. So it is estimated up to, so you're going to see a ton of different ranges. So I always go with the highest, not to be the scariest, but just because you never want to underestimate a risk. I would rather overestimate a risk and make sure that we are being prophylactic and doing the appropriate interventions than underestimating and not making sure that people are motivated to do what they need to do to stay on top of their screening. So up to an 80% lifetime risk for developing breast cancer. Now this has everything to do with something called penetrance. Now every gene has variable penetrance. And that means that some patients who have a BRCA1 mutation, their entire family is filled with ovarian cancer. But some people who have a BRCA1 mutation, nobody has ovarian cancer and everybody has breast cancer. That's telling you that it has a variable penetrance. In the one family, it is more penetrant for the ovarian. In the other, it's more penetrant for the breast. And that really helps us in deciding how we should sequence our appropriate interventions for patients when we're looking at a family history. There's also an up to a 40 to 60% lifetime risk for developing ovarian cancer. And also it's associated with cancers of the pancreas, prostate, and melanoma. So about 5 to 10% of breast cancer and 10 to 15% of ovarian cancers are hereditary. That means that 1 in 500 women in the US has a BRCA mutation. We know that it is inherited autosomal dominantly, which basically means if you have it, there's a 50% chance that all of your offspring have it. And then it's more often seen in Ashkenazi Jewish, Caribbean, and African American ancestry, although I have patients from all over. I have an Irish woman who has in literally Irish, she works at an Irish bar and has the sweetest accent, and she has a BRCA mutation. And it really just has to do with the world is really a melting pot now. So there's so many mixtures of gene mutations that can be seen. But the reason this is so important is you need to get your appropriate screening. So by guidelines, if you have a gene mutation that puts you at a higher risk for developing breast cancer, so that includes the ATM, you should be screening on a high-risk screening protocol. And a high-risk screening protocol is alternating between bilateral breast MRI and bilateral mammogram plus or minus ultrasound if you have dense breast every 6 months. And the reason we screen people every 6 months is you have a higher risk of developing breast cancer. So if we screen you more frequently at a different interval than we would screen the general population, who we call average risk, we are more likely to find disease at an earlier stage with less long-term impact. So that's clearly a recommendation, and you should be doing that. And you might also discuss with your team, your care team, about the consideration of prophylactic bilateral mastectomies. And I'm saying consideration because if you look at the NCCN guidelines, it really says have the discussion, okay? So it's consider the bilateral mastectomy. I will tell you that the majority, with the exception of my older patients, and by older, I'm saying like in their 70s, who are found to have a BRCA mutation at that age, a lot of them will not have mastectomies at that age because they'll just continue following. But my younger patients, the anxiety becomes overwhelming because the treatment of cancer is very different than the treatment of a prophylactic intervention. And prophylactic surgery is not without risk. You can have multiple long-term complications, but the one thing that you really minimize the risk of is recurrence of cancer somewhere else in your body. And I think that that provides some degree of peace of mind. So that is one of the recommendations. High-risk screening protocol, have a discussion based off of family history regarding risk-reducing bilateral mastectomies. The next thing is to recommend, I'm sorry if you can hear my kids screaming, they're two boys and they're crazy, but to recommend risk-reducing bilateral salpingo-oophorectomy. And what that basically is saying is remove the ovaries and tubes. We know that a lot of these BRCA and BRCA-like mutations, so PALB2, CHEK2, ATM, PBL1, there's a whole bunch of them that have very similar BRCA-like risks, slightly lower risks of developing the cancer, but it depends on the family history and the penetrance, to clearly recommend in those cases to remove the ovaries and tubes. And the reason why is we don't have good screening for ovarian cancer or tubal cancer. Unfortunately, oftentimes, despite our best efforts, even if we suspect that it could happen at some point, we oftentimes find it late and the risk of recurrence remains high. So we do everything we can to minimize that risk. So the recommendation for BRCA1 is between ages 35 and 40, or when you're done with childbearing. And the recommendation for BRCA2 can be up to 10 years later, but typically the recommendation is between ages 40 to 45. There are some subsets of BRCA1 mutation carriers who actually do have an increased risk for a sarcoma-like uterine cancer. So in some cases, there is a consideration of removing the uterus and the cervix as well. So you might be asking, what actually are the breast cancer screening guidelines? And I think that this is a really appropriate question. Number one, because women between ages 40 and 49 are dying from this disease, but also because we know that these numbers are not declining in that same age population. And over the last several years, there were multiple different discussions of when you start screening. So what are the guidelines? The US Preventative Task Force says start at age 50. American Cancer Society, start at age 45. However, I want you to see all of the rest of these are medical associations with doctors who actually care for the patients who are affected. And the hands down recommendation is the latest you start is age 40 for your average risk. If you have high risk, you would start at least 10 years younger than the earliest diagnosis, or if you have a gene mutation, we recommend starting no later than age 25 with some type of screening. So what should you do? We start screening at 40 and we recommend doing so annually. If you do have a family history, you need to start 10 years prior to the youngest breast cancer diagnosis among your first degree relatives, but you also need to know your breast density. The reason you need to know your breast density is you have to advocate for yourself. Not all OBGYNs or primary care doctors know that ultrasound is also indicated for breast density. So you can actually ask your mammographer, can you tell me what my density is? Or when you get your mammogram report back or your doctor calls you with the report, you ask them, could you tell me what my breast density is? If they tell you that you have dense breasts, you need to say, well, I have dense breasts. Shouldn't I be getting an ultrasound too? We have to advocate for ourselves. Exactly what I said there. See, I forgot that that was the next thing. Okay, so what is mammography? We have two different types. There's the digital mammogram versus the tomosynthesis. Regular screening obviously increases the chance that breast cancer is found early, but we know that no test is perfect. However, routine screening reduces the risk of dying from breast cancer by about 20%, and that's an absolute 20%. With newer techniques, it's likely closer to 40%, but we know that you can have false positives, overdiagnosis. It's a small dose of radiation. When I have patients who say, oh, I didn't want to get mammograms because it's too much radiation, I ask them if they would fly to Chicago to go for a nice weekend, and they always say yes. And I say, well, flying gives you more radiation than a mammogram. And then it kind of makes them question whether or not that logic actually is sound. And it doesn't catch all cancers. However, it is still the single most effective method of early breast cancer detection. Ultrasound, like I said, you use it to evaluate abnormal findings on mammogram and physical exam. We use it for dense breast, but it's not recommended for routine screening alone. And then for high-risk screening, we do recommend MRI starting at the age 30 at least. No radiation exposure. It is far more expensive. For patients who are claustrophobic, it can be an issue. A breast MRI is actually face down with your breast hanging down into holes. So for a lot of women, that is a problem, but it serves as a supplement to mammography. It is not a replacement. But what can prompt off-cycle imaging? So whether or not you're being screened on a high-risk screening protocol alternating between every 6 months or annually, these are the things that can change you to getting imaging sooner, okay? Number one, know the texture and density of your breast. Despite the fact that many of the big societies like the American Cancer Society and such do not recommend routine breast exams for the patient, like self-breast exams, physicians advocate for it because so many patients discover their own cancers while they're showering or dressing. And honestly, I've had a ton of patients who their partners have found it. So it's really important to know your breast, know what they feel like, know what they look like. Look at them when you get out of the shower. Make sure that they're symmetric or know the fact that they're asymmetric and that's normal for you. Most breast lumps are not abnormal, but I always tell my patients, I want you to make me prove to you that it's not abnormal because then you can put your head on your pillow at night and know you don't have cancer, and I can put my head on my pillow at night knowing that you don't have cancer. So if you notice skin dimpling, nipple inversion, nipple discharge or bleeding, a lump in the breast or in the axilla, or a new asymmetry, you should seek evaluation prior to when you're due for your imaging. So now we're going to transition a little bit because I think that this data is so fascinating, and we are now, 7 months into this, the pandemic in this country and with close downs, and we're now seeing how this has impacted patients. I can tell you I have many more patients coming in with lymph node involvement, stage 3 and beyond, who felt lumps in January, February, and then were planning to see their doctors in March, and then everything closed down and it became too fearful. And now here they are 6-7 months later, and they have at least locally advanced disease. So this is showing you the percentage change in cancer screenings during COVID-19. So on the left side, and this is showing for cervical cancer, colon cancer, and breast cancer. On the left side, that's February. Then you can see March 1st, and before April 1st, there is this drastic decline by more than 80%, which is just astounding. And those numbers stayed low all the way through May with a very slow increase, but we're still not up to where we would be. So the question then remains, if we're not superseding the screening that we would normally be doing, what happened to all of those patients who missed? They're not making up for it now. So I think that this data is going to have a really long-term impact. So we saw that it led to at least an 80% drop through March and April, and that's estimated to be 60% fewer breast, colon, and cervical cancer exams just from March to June, and that's in comparison to the years prior. And this translates to hundreds of thousands of patients who miss their exams nationally, but sadly, this is the most important point. For those patients who had undetected cancer or a precursor to cancer, they've now lost the potential for an early diagnosis and intervention altogether. You can see here, and this is looking at breast cancer specifically, and the baseline is, this is compared to the 60 weeks average prior to March 1st. So this is a weekly average, but that baseline average is for the prior 60 weeks. So for the prior more than 1 year. And this is looking at the newly identified cancer just from Quest alone. And baseline average is 2,200 March 1st, 2,000 March 8th, 1,700. And look, we get all the way down to 1,000. And we've stayed pretty steady with that. So we know that we're missing 1,000 patients per week. And those patients are yet to be made up for. So what does that actually mean when we're talking about the impact on cancer treatment? Initially, it was really hard as an oncologist. We took into account a risk-benefit analysis of delaying care or risking patients to be immunosuppressed and basically being more at risk for a potentially deadly infection through the pandemic. So 44% of breast cancer patients that were surveyed, and this is among tens of thousands of patients across 607 breast cancer areas, reported that their treatment had been delayed. And you can see what they were delayed in: genetic testing, oral therapy, their surgery, radiation, chemo, their ovaries being removed, lab tests, diagnostic testing, breast reconstruction, and then routine follow-up clinic appointments. So the long-term impact obviously remains to be seen, but the NCI does estimate that the COVID-related delays in screening and cancer care will result in at least an additional 10,000 deaths over the course of the next decade, just from breast and colon cancer alone, and that's already on top of the 1 million expected deaths from those diseases. So this assumes that the pandemic only lasts for 6 months. The delays only last for 6 months. And we're still already into our 7th month and seeing these same delays. And this is just showing you that by 2030, that's going to be the cumulative excess deaths that we will see. And it's heartbreaking because those slides that I showed you at the beginning with death rates decreasing with respect to all cancers really gave us so much hope that we were doing the right thing. But it shows you that we just need to do better at educating and being prepared for wrenches that can be thrown into that plan. And I think that this country has learned quite a bit of how we would deal with this if we have to in the future. So how can we change this negative impact? And really, this is the most important take home, is cancer screening is essential. It is not an elective procedure, and it is widely available. And safety precautions, because so many of my patients are still fearful of going to get their screening because they're afraid they're going to get COVID and they're terrified. But safety precautions are being taken to protect the patients and the staff. You have to remember that the staff in these locations can be just as fearful. But what I need you to know is that mammograms, and in cases of high-risk screening, MRI and ultrasounds do save lives. And then this is the quick little picture of my new home, and I can't wait. The oncology floor will be on the top floor, so we have a beautiful view of a lake in front of us. And obviously it will have all of the support services that oncology would require with a full research department. I know this doesn't apply to everybody, so I'm gonna just flip straight through it. And then I just think that this is important to know. It probably doesn't affect any of you, but with October being tomorrow, actually, and it being Breast Cancer Awareness Month, almost every single imaging center in the country, I know I work for Baptist, but that's not what I'm discussing. Almost every single imaging center in the country has discounted mammograms, diagnostic mammograms, bone densities, pelvic ultrasounds, and even MRIs and 3D mammograms. So I think if you know somebody who doesn't have insurance, now is the time. Go get screened because it is widely available. But most importantly, you need to remember that you are your best advocate. You know your body, you know what you're feeling. You have to bring that to our attention. If you're concerned about something, you need to seek evaluation. Don't think that anybody's going to think you're a hypochondriac. Nobody does think that. You have to advocate for yourself. Know your risks and your family history. It's so important. I know that families don't like to talk about cancer, and in many cultures it's taboo. But if you can share this information or share the fact that your aunt and all of your cousins had cancer, it really could potentially save your life. So it's so important to ask the questions and pry this out of your family members. But most importantly, please get your screening, get your mammogram, get your ultrasound, get your MRI, because they absolutely do save lives. So thank you so much. I hope, let me see if I can stop sharing, that was helpful. I know that it was a lot, but if you guys have any questions, I'm happy to answer anything.
So what we'll do is, if you guys want to raise your hand if you have questions, you can, or you can unmute yourself and ask them. Go ahead.
Okay, so
Who? Me?
go ahead, Diana.
Oh, okay. So my sister had this same breast cancer 7 years ago, but nobody's mentioned to me about getting genetic testing.
So was your sister postmenopausal when she was diagnosed?
Yes. And I also
So-
have a cousin who had it too.
So for me, I would test you, okay?
Okay.
And I think that we could make it work in your genetics and in your family history in order for it to be covered by your health insurance. But to me, if you and your sister have been diagnosed, it could potentially give more information that can really help prevent this from being an issue on the other side in the future, right? So I would talk to your doctor about it. I think that honestly, I know that I get it because I'm a community physician, okay? I am not part of a big, now my dog's barking, I'm so sorry, you guys. I am not part of a big academic institution where I don't understand what community doctors do. I do, but I am fortunate enough to work in a hybrid practice where I can practice what I know. And I think when you're out in a community setting that doesn't have all of those resources and you're dealing with general hemoncs, you don't always get the resources and the questioning that you might get when you're dealing with a specialist. So I absolutely would have you tested because I think it would be helpful. To be perfectly honest, you're likely to be negative, okay? In your highest likelihood is to be negative.
Oh, okay.
But I think that you should consider it.
Okay.
Especially for your children. I don't know if you have children, but it would be important for your children.
There's
Anybody else?
in the chat, if I have an ATM mutation, what increased risk am I at for breast cancer? I've heard varying ranges.
So there are varying ranges, and that has so much to do with penetrance. So typically it's quoted around 30 to 40%. But I have many patients who have no family history. They came in because they were young with breast cancer and we did genetic testing. They were found to have an ATM mutation. So the actual rate is absolutely higher than the 20%. So you're for sure high risk. So your screening should be every 6 months, alternating between mammogram with ultrasound if you have dense breast and bilateral breast MRI. The discussion of whether or not you would do something prophylactic really ultimately is a personal decision, but you would want to take into account your family history. Because if you have a family history of a lot of breast cancer, that actually might motivate you more to pursue a more aggressive prophylactic intervention like a risk-reducing mastectomy. However, you don't have to do that, but you should for sure be on the high-risk screening protocol. Anything else?
Does anybody else have questions?
I don't know how relevant that is, but as you're talking about risk factors, I was wondering about breastfeeding. I know that sometimes it comes up. Is it something that matters at all in terms of your risk or not?
So breastfeeding actually can be protective. Not breastfeeding doesn't necessarily increase your risk, but breastfeeding can be protective. The recommendation is at least 6 months of cumulative breast cancer. I have read on varying sources that it's 6 months all in a row, but then there have been other specialists who have actually said, well, no, 3 months with one child and 3 months with another child is enough to count for the 6 months. I have traditionally always learned that it was 6 months consecutive that provides benefit. Our breasts don't fully mature until we lactate, which is one of the reasons that people who do not have children are at higher risk. That's when, it decreases the density too. I don't know if any of you have breastfed, but after I breastfed, my boobs didn't face straight anymore. So it definitely decreased my density.
Okay. Thank you. That's helpful.
Yep.
Did anybody else have any other questions?
I do. I have another question. So I've been doing a lot of research. Since I'm just brand new to this. And one of the things, and this was my gynecologist, I moved to Florida from New Mexico, and my gynecologist in New Mexico, I called him because I value his opinion. And one of the things that he said about using the estrogen inhibitors was there's been studies done showing that if you use it with testosterone in a pellet form, that it alleviates all the side effects of the inhibitor and protects you against breast cancer. Have you heard anything about that?
So that's not fully true, okay? It can help reduce the side effects of the anti-estrogen, but there are many breast cancers that are actually androgen receptor positive. So they actually are fed by testosterone. And that's why in some cases I've treated I have a young woman who has had stage 4 disease since she was in her 30s. She's now like 48. But she has androgen receptor, and we've actually used testosterone blockers, androgen receptor blockers that would normally be used in prostate cancer for her treatment at points in time. So I wouldn't do that. I think that is too high risk. Yes, you'll probably feel better. Yes, you'll have a better sex drive, as men typically do over women, right? Because they have a far higher levels of testosterone. But I wouldn't recommend that to any of my patients. And in fact, I think that it would probably be a liability.
Okay.
Anybody else?
I have a question in regards to your comment, and I'm not quite sure if I followed you correctly on the hormone replacement therapy. I'm currently 48, went through the BSO and on an anastrozole. And so would that be, no.
So the reason why is because you're on the anastrozole. Once you've been diagnosed with a cancer, with a hormone receptor positive cancer, the risk of doing hormone replacement therapy would actually be feeding the risk of disease recurrence.
Okay.
What I'm talking about, hormone replacement therapy, and this is a very personal decision per patient. I know that there are many BRCA patients who will not touch it. There are many who will, okay? And it's a discussion with your doctor to figure out your comfort. But if you are, so say I found out that I have a BRCA mutation because my sister just had breast cancer and she was positive, so I decided to get tested. And I found out I'm positive. I do all of my screening and I have no evidence of disease, but I say, I'm going to get my breast removed tomorrow and I'm getting my ovaries and tubes out next week, right? So you do all of that prophylactically, no evidence of cancer. I could take hormone replacement therapy without an increased risk of having breast cancer or cancer in my future.
Excellent.
Okay.
Thank you for clarifying that.
Yeah, so it's really the prophylactic setting.
Very good. Thank you.
Mm-hmm.
Any other questions? Thank you so much for coming on, Dr. Carcas. We're forever grateful for your dedication, your commitment to making a difference in our community. So thank you again.
It's my pleasure, and I'm happy to do it again. And Diana, I owe you the names of the doctors up in Melbourne, okay? And I'll get those to you, okay?
Thank you.
All right, perfect.